Hi, thank you for the introduction, Christina. I'm an assistant professor at Georgia Tech, and what I'm presenting today is joint work with Rajesh Chandwani. He's a colleague at the Indian Institute of Management in Ahmedabad. He could not be here because he did not have his visa, but I'm presenting really on his behalf. Our paper is on stitching infrastructures to facilitate telemedicine in low-resource environments. First, I'd like to ensure that we all have a common working definition of telemedicine. Telemedicine entails remote delivery of health-related services by transfer of audio, video, and graphical information via information and communication technology, ICT, and can include diagnostic and consultative services. Telemedicine can potentially transform healthcare delivery by allowing for the extension of medical knowledge to remote locations, enhancing the efficiency and effectiveness of a larger, complex healthcare infrastructure. I'd like to start by sharing my own recent experience with telemedicine. I was recently in San Francisco, California, and I found myself suffering from pain in my arm. And this was actually right after the Chi rebuttal deadline, and I had been typing away for a few days. And I have insurance coverage in the state of Georgia and was looking online for a doctor that I could see to fix this pain. And I found a place on Google that was 3 blocks away from me, and I called. And it turned out that this facility was a telemedicine facility, which meant that even though it was just 3 blocks away, I could not see a doctor in person. I would have to call in and do a teleconsultation. And it didn't make a lot of sense to me because I was in San Francisco, which has quite a robust healthcare infrastructure. I was protected by decent healthcare insurance. I could afford many decent options. I was not remotely located and also quite mobile, willing to travel a good distance to seek good care. But these aren't privileges that are accessible to a lot of people, to many people across the world, and specifically in the global south. And telemedicine systems can certainly be designed to be more contextually and ecologically appropriate, where their particular affordances could be better appreciated, as we found with our study of a telemedicine implementation in India. We studied the telemedicine program in the Department of Surgical Endocrinology in the Super Specialty Public Health Institute, which I'm going to call NIMR or NIMR. This institute is located in Lucknow in the state of Uttar Pradesh in India, and it offers a wide range of specialty and super specialty medical services to a large and growing population, not just from the state of UP, but diverse and remote locations in India. The program that we studied was designed to connect NIMR with state medical colleges in the state of Orissa. And to give some background, these colleges provided specialty services such as general surgery, but they did not provide super specialty services such as surgical endocrinology and radiotherapy. So several patients with thyroid cancer would be referred to super specialty institutions such as NIMR for treatment and follow-up, and you can kind of see that the distance is not small. The problem is that tertiary care centers in India, like NIMR, see heavy patient traffic and may require extensive and expensive travel to seek treatment. For example, the travel between the points that I just showed you takes, on average, more than 24 hours, and it involves substantial costs for the patients due to traveling expenses, loss of wages, boarding, lodging, food, among other things. Further, there are cultural gaps, including language barriers, which can make accessing these centers more difficult. These aspects make tertiary care hospitals in India challenging to access, particularly for patients who are remote. Telemedicine then has the potential to circumvent these gaps or at least mitigate their impact. The heads of the Department of Surgical Endocrinology and Radiotherapy set up a telemedicine program at NIMR with peripheral centers in Orissa so that patients from Orissa could access these super specialty services without incurring travel expenses. Most thyroid cancer patients need a detailed assessment, possible surgery and or radiotherapy, strict follow-up schedules, lifelong adherence to medication regimes, and repeat laboratory assessments. So physicians at NIMR proposed that a telemedicine system be designed so that it could help in providing follow-up consultations. So once the patients had undergone surgery in Lucknow in Uttar Pradesh, they could then do the follow-up sessions in Orissa. So that was the setup. And after undergoing this primary treatment, all of the consultations would be held using telemedicine. These are the actors who were involved in the telemedicine setup, and they're pretty key to understanding what our study was about. So the super specialists and the coordinators at NIMR, the super specialists were the ones who were actually the medical experts, and then there were the coordinators who were making sure that the system was working from a technical standpoint. Then there were the local physicians and surgeons, the coordinators in Orissa, and these were the ones who made sure that things happened appropriately from the physician standpoint, but also from the technical standpoint of just setting up the system. And then there were the patients in Orissa, who were obviously the main stakeholders. And there was extensive training on the management of thyroid cancer, which was provided to general surgeons from the medical colleges in Orissa by super specialists at NIMR. There were doctors, coordinators, and technicians in the fray who all had received training at the beginning. This is the data that we collected, and specifically we were looking for insights on designing an effective telemedicine system, and we studied how teleconsultations took place here before, after, and in between sessions. A quick note on ethics. So this work took place only after multiple university and hospital approvals were sought and granted. Before each session that we observed, we informed patients and the family members present about the goals of our research and what the process of data collection would entail. We added that these observations would have no bearings on the medical treatment, that they could opt out whenever they wished, and we then sought their and their family members' consent. After this introduction, we witnessed the consultation process seated away from the camera's line of sight so as not to cause distraction. No patients showed visible discomfort or asked questions about the process, the data collection process. One reason may have been that the telemedicine consultations were never one-on-one, so there were coordinators who were always present on both ends at all times to ensure that the links were working. Further, the topics that were discussed was not as sensitive or linked to social stigma as others might be, for example, those related to sexual or reproductive health. Patients were not given any compensation as the hospital supervisors recommended. Initially, we had thought that our focus would be on the doctor-patient interactions, and that's what we had kind of started out with. But we found through this study that we were increasingly drawn to what happened before, after, and in between these doctor-patient interactions. And as we coded our data, we also discussed our findings and insights with the physicians and the residents who were part of this study. So what perspective does our study add that is novel? Well, first, to connect rural patients in remote rural areas to super specialists in urban tertiary care units entails messy and unarticulated overlap between the urban tertiary care system and the local healthcare system. This juxtaposition entails seamful spaces that emerge when we try to layer technology interventions atop pre-existing assemblages that the technology is trying to connect to and extend. The delivery of healthcare in such situations involves life-critical discussions and the need to share complex medical data, so it requires considerable and careful communication between the doctors and the patients working around the seams. Second, our research draws attention to the human infrastructures that connect these seamful spaces. Overcoming the challenges imposed by the seams entails, as we found, specific human actors in the design and the implementation of such a system. Earlier studies have highlighted the criticality of human infrastructures for overcoming challenges of seams across various dimensions, sociocultural, technological, infrastructural, and we built on prior work in infrastructure studies, particularly Sambasivan and Smythe's work, to examine the articulation work that was being performed towards seamlessly stitching together infrastructures so that we could overcome the challenges for delivering healthcare in this implementation. So I'll now present what we found about these infrastructures. Finding number one was there was extensive center-periphery coordination. So there were coordinators at both nodes, and they assembled approximately an hour before the consultation began. They would then check the technical aspects of the system, ensure that all prior data of the patients was available at both nodes, and confirm that all relevant actors had been informed. So for example, coordinators at the central node in Lucknow would check to see if all patients had been informed and how many of them were expected to arrive. Coordinators at the peripheral nodes then shared information regarding their phone conversations with the patients and identified the patients who would not be attending. And so these files would be removed from both ends, after which the coordinators would tally the lists again. And this process kind of happened repetitively until they were sure that the schedules were packed and all of the patients were attending. So this is a quote from the department head at the surgical endocrinology unit, who said, "These coordinators are the backbone of the telemedicine system. I mean that they run the show. I have my patients, my OPD timings, and my scheduled surgeries. I don't get time to think about technical aspects, whether the connection is there, the camera is functioning, etc. They ensure all of that. I just walk in the consultation room, the patient is ready, the files are up to date, and the residents brief me about the case. It is same like seeing the patients in my chamber. Well, almost." The lead coordinator of the program at Neha explained the importance of ensuring that everything was unfolding smoothly, saying, "We need to address multiple issues to make the teleconsultation process a success. These patients travel from far-off rural areas to the respective medical colleges to attend the teleconsultation. We can't afford any technical glitches. We double-check the connectivity aspects a day before and a few hours before the actual consultation time. I am in constant touch with the coordinators at the other end." In addition to checking things at either end, they also needed to ensure that things were good on both ends in tandem. So as one coordinator said, "We make sure that all the preparations are done well in advance. It requires a lot of planning from both sides, here as well as the medical colleges. We discuss with the super specialists here and prepare a list of patients according to the follow-up dates given to them." And then another coordinator mentioned the arrangements that they need to make. So a central finding in our study was the articulation work that is performed by the coordinators, mostly offline, to ensure that all the online processes are carried out without glitches. And to ensure connectivity and infrastructural stability, the peripheral nodes needs to be located where basic infrastructure such as electricity, hardware, and internet are at least moderately reliable. And this is why we chose medical colleges at the peripheral nodes. So the patient still had to travel to these medical colleges, which was not a long distance, but because there was basic infrastructure available at these colleges, it facilitated the process and made it smoother. The second set of findings was just the role of local doctors as key stakeholders. So these were the local physicians and surgeons who were at the medical colleges in Orissa, who assisted in providing care, and their training also helped in the local upgradation of skills over time. The senior surgeon at the Orissa Medical College said, "I now know about the management of thyroid cancer patients and can even perform the surgery. I did not learn these things in my medical college." And a physician at the Orissa Medical College also said, "We continuously learn and upgrade our knowledge about thyroid cancer during these teleconsultations." So prior work has highlighted the importance of the primary care physician or family physician in the successful implementation of telemedicine initiatives. What we really saw was from the perspective of upgrading knowledge and skills over time. The third set of findings focused on patients' involvement. Patients were evidently confident and fluent in their interactions during the teleconsultation, and this is across the 62 sessions that we saw. They also showed evidence of learning disease-relevant vocabulary over time. As one of the doctors in Orissa said, that he felt that these patients were more proactive and also more precise, and he contrasted them with the patients who they saw in typical face-to-face follow-ups, saying that when the patient was being sent home, they would tell them to get the test done and bring the reports, but there was no prompting that happened. But in the case of the telemedicine, since costs were higher, they made sure that this prompting took place so that patients then knew to do these tests. Patients also affirmed our findings, so saying that when the doctors and the coordinators from the medical college call us and tell us in detail, we tend to learn. And one of the patients also said that he maintained a diary which helped him to communicate fast with the doctors in the large hospital. So there was this sense that we're communicating with doctors who have less time, so how can we make that process smoother? And then a senior resident at Neha also said that there were, with the repeated follow-ups, these patients became pros. And you can't really guess that these patients are illiterate and uneducated. I have 2 minutes. Okay. So quickly, the takeaways, right? So how we stitch together these infrastructures and why that's important. So these are seamful spaces. They are, as I mentioned, we're looking at the center and the periphery, the rural and the urban areas. And there are several challenges, so challenges with various kinds of resource constraints. and I'm trying to see how I can pack this into 2 minutes. So theme number 1 was unreliable connectivity, which we understand is often a case, right? So what they did was just make sure that there was a plan B, a plan C, and so on, so that they could ensure that there was basic infrastructure and there were many different options. So when things did not work out, there were other things to fall back on. Theme number 2, complex moving parts. As I mentioned, there's all these different actors with many different schedules, and all of those kind of need to come together. So the coordinators would do their homework well and make sure that the workflows of the doctors were aligned, and then the patients did their tests before and after to make sure that that process was smooth. Low expertise at the periphery. So as I mentioned, the local doctors did not have enough training to begin with, but they had been involved from the start and had been trained from the start. And so that ensured that over time they were also kind of upgrading their skills. And then low patient awareness. Again, as I mentioned, patient involvement was a key finding. And we saw that patients were not just passive recipients, but there were multiple touch points between the coordinators and the patients, which helped to ensure that over time they were much more engaged in their own treatments. Okay. So to quickly then summarize what we found, right, in this the case of the telemedicine implementation that we studied. So there was a central node at Lucknow, the peripheral nodes in the medical colleges in Orissa. There were time constraints in Lucknow, but there were other constraints, specifically cost constraints, that were most central in the Orissa sites. And there were certain decisions that were taken with the roles of the coordinators that were particularly helpful in ensuring that this was a successful system. And these are the main things that I would say were our takeaways, particularly for a telemedicine setup in resource-challenged settings, but perhaps also for other settings where there are where it's not a telemedicine setup, or in cases where you might have distance education, for example, and you're looking at a central and peripheral node. So what are the things that could make this process smoother, though there might be other challenges as well? So one, choosing the right nodes to leverage existing infrastructures. And this was with regards to the choice of the medical colleges as sites, as opposed to where the patients were located in different villages and in small towns. Second, to ensure that coordination at both ends addresses acting constraints with available assets. That is, leveraging local physicians or surgeons as co-designers in the process, and leveraging patients as co-creators. And there's much more detail in the paper, but I'm happy to take questions now.
We have time for 1 or 2 questions.
Hi, I'm Daniel from the University of Bremen. Thank you very much. Great topic. I have a question regarding generalizing your findings. Mm-hmm. Do you think this could also be applied, for example, in Africa, other countries? Like, how much of this work is related to the infrastructure with the medical colleges, for example?
Yeah, I mean, that's a great question. I don't do a lot of work in Africa, so I don't really want to speak for the whole continent. But I would say that there are challenges that we saw that might be generalizable to other contexts as well. So, for example, the fact that, super specialty clinics or tertiary care centers are kind of distant from where the patients might be. And so how do we bridge that gap without making the patients travel every single time? And so trying to find that right combination between just making sure that the care that they receive is correct, is right, but then the follow-up sessions can happen remotely. I think that's also something that might apply in the developed world, the global north settings, right? So trying to see where follow-up sessions are required and how those could take place maybe with local doctors versus the more important sessions that need to take place with the specialists.
Okay,
yeah.
Thank you.
Hey, thank you so much. I've really
Hi,
enjoyed
Rajesh.
your talk. I'm really interested in the work that patients were doing to prepare to communicate quickly with their doctors.
Mm-hmm.
I was wondering if you could just elaborate a bit more on the kinds
Yeah.
of things they were doing.
Actually, that was the most exciting finding for me also. I think, and especially the difference between the same patients coming for their follow-ups at the local colleges versus coming to the colleges for this teleconsultation. And I think what I would say helped was the follow-up sessions in between. So they really kind of understood that they needed to do these follow-ups because the time of the specialist was really critical. And the other thing was just, over time kind of building that culture, which I don't know if it would be possible across different kinds of diseases. Like this was in the case of thyroid cancer patients, and so they needed follow-ups, but maybe in other less chronic diseases that might be more challenging. Certainly worth